Carlos and the association in general, first of all, thank you very much for asking me to talk, and thank you for all the work that you're doing to raise awareness and galvanize the patient voice, which I think is very apt at the moment. So thank you. I thought I would start, so I'm going to talk about cardiomyopathy, or the cardiac aspects of ATTR amyloidosis, and I thought I would just start with a quick slide on medical jargon, because you're at risk of my using medical jargon and hopefully explaining some of what we're saying. So ATTR amyloidosis or TTR amyloidosis is what we call transthyretin amyloidosis. You'll see us referring to hATTR or ATTR-V, and the H stands for hereditary or variant. Wild type, as Mary explained, is the non-hereditary or acquired form of ATTR amyloidosis. Cardiomyopathy is a term that refers to a heart condition in general. You may hear me talking about regression of amyloid, and by that we mean removal of amyloid from the body. You'll hear me talking about cardiac MRI scans or cardiac magnetic resonance imaging, which is a scanning technique which has proven fairly recently to be very, very useful for diagnosing cardiac amyloidosis. And then another scanning technique, a DPD scan, which is done in a number of centers now around the UK, about 25 centers in total, which is another scanning technique which is exquisitely sensitive for looking for ATTR type amyloid in the heart. It can also pick up other types of amyloid, but it's particularly sensitive for ATTR amyloidosis. So I'm going to talk to you a bit about the epidemiology of cardiac transthyretin amyloidosis, or ATTR cardiomyopathy, a bit about the advances in diagnosis and staging. I'll talk to you a bit about the management and treatment principles for amyloidosis in general, and in particular ATTR amyloidosis, and then talk about the treatment advances and forthcoming trials for patients with cardiomyopathy. So just to recap on some of what Mary explained, essentially there are a number of different proteins that can form amyloid in the human body, and the particular protein that we're talking about today is this protein TTR, or transthyretin. And ATTR amyloidosis can either be wild type, when that protein is not mutated, it's a structurally normal protein which happens to misfold usually in older age, or the hereditary version, in which the protein, there's a genetic mutation in the protein, of which there are many, as Mary explained, which gives rise to misfolding and deposition as amyloid. And then there are various other different proteins that can form amyloid in the body. And this graph at the bottom here is just to show you that about 30%, the vast majority of patients we see with hereditary amyloidosis have hereditary ATTR type amyloidosis. So ATTR amyloidosis accounts for about 30% of patients that we see here at the National Center. And it is important just to be aware that differentiating the different types of amyloidosis can be quite a challenge. And it's important to do so because the different types of amyloid behave very differently, and they're also treated completely differently. So for example, you can have AL amyloidosis affecting your heart, or you can have ATTR amyloidosis affecting your heart, which is what we're talking about today. Well, in AL amyloidosis, the treatment is with chemotherapy, whereas in ATTR amyloidosis, the treatment is very different, and I'll talk a bit more about that later. Wild type ATTR amyloidosis, as we said, the amyloid protein is normal, non-mutated transthyretin, and the predominant organ that's affected is the heart. It causes a cardiomyopathy, a heart condition. And it's an increasingly recognized cause of what doctors call heart failure. It's a horrible word, but essentially heart failure is breathlessness related to a problem with the heart. And it typically affects people over the age of 50. And interestingly, actually in post-mortem studies, you do find ATTR amyloid deposits in 25% of males who are over the age of 80. So this condition undoubtedly becomes more and more common as one gets older. One of the things that we don't know is that the vast majority of those individuals, 25% of the male population over 80, is a huge number of individuals in this country and all over the world. And what we really don't know is the vast majority of those people are not diagnosed with clinical amyloidosis or cardiac amyloidosis during their lifetime. And what we really don't know is how many just have amyloid deposits that are not causing a clinical disease, and how many go undiagnosed. They actually had a cardiomyopathy, a heart condition, they had breathlessness, they died because of this breathlessness, had a post-mortem, it showed amyloid, but actually their diagnosis was never made. They had a significant clinical disease that wasn't made. This is on the panel on the left here is an echocardiogram, what we call a 4-chamber view of an echocardiogram. And what it shows is these very thick, these white bits here, the heart walls, and you can see this is a very thick heart wall, and this is what you get in amyloidosis. This is a histological section, a biopsy section through a whole heart, and you can see that these heart walls are very, very thickened. They should be much, much thinner than this. And this is because of the deposition that Mary talked about of amyloid in between the cells in the heart, which causes this thickening, or what we call hypertrophy, thickening of the heart wall. This panel on the right just shows you that the number of diagnoses, particularly of wild type ATTR amyloidosis, the non-hereditary version, which is predominantly a cardiac disease, have dramatically increased in recent years. In the year 2000, we had one patient who visited the center who was diagnosed with wild type ATTR amyloidosis. And as you can see, this has increased dramatically over recent years, and I'll touch on why that might be. Mary's talked about this in a lot of detail. I won't go over everything. Just suffice to say that, as Mary alluded to, there are more than 130 mutations, genetic mutations of the TTR gene that can give rise to hereditary ATTR amyloidosis, which, as she talked about, causes both a cardiomyopathy and a peripheral and autonomic neuropathy. So it affects typically both the heart and nerves. And there are different mutations that tend to give more of a neuropathic picture, and there are other mutations that tend to give more of a cardiomyopathy and little in the way of neuropathy, but there's a lot of overlap. And I saw a question about why does the phenotype, I saw a question today about why does the phenotype, why does the disease vary in this different individuals from the same family? Why can one family member present with neuropathy and another family member present with cardiomyopathy? And that is not unusual, in that different members of the same family can have, one can have a more aggressive heart disease and the other one can have a more aggressive nerve disease. But essentially the condition, most of these 130 mutations can affect both the nerves and the heart. There's one particular mutation that Mary also mentioned, and I just wanted to highlight, and that is the V122I mutation. Isoleucine 122 is the long term for the I is isoleucine. And that particular mutation, genetic mutation, is present in 4% of people of West African descent and Afro-Caribbeans. So 4% of Black people in the UK carry this genetic mutation. And that puts them at risk of developing predominantly a cardiomyopathy. The clinical condition is very similar to the wild type ATTR amyloidosis and causes a predominant cardiomyopathy with usually a minimal or no neuropathy. Although, again, occasionally patients can have very significant neuropathy. So the reason there were so few diagnoses a few years ago, as I showed you in the earlier slide, is because the diagnosis of ATTR amyloidosis is challenging. And in particular, it's challenging because until recently, the diagnosis was made by a biopsy. The diagnosis of amyloid had to be made by a biopsy. And cardiologists do not perform a heart biopsy for every individual with heart failure. Heart failure is an incredibly common condition, and cardiac biopsies have risk, they're complicated. So cardiologists rarely perform cardiac biopsies. And so it was challenging to diagnose amyloid via cardiac biopsy. An alternative was what we call a screening biopsy. So to do a biopsy from another part of the body to see whether you can pick up amyloid deposits in another part of the body. Typically, in the past, one did rectal biopsies in order as a form of screening biopsies. Some of you will be familiar with the more recent screening biopsy that is performed, and that's usually an abdominal fat aspirate, where we suck out a little bit of fat from your tummy. Many of you will have undergone that procedure when you attended the center. The problem in ATTR amyloidosis is that fat biopsies, as you can see from this slide at the bottom, are not very sensitive. So most patients with ATTR amyloidosis who have a fat biopsy, the fat biopsy will not show amyloid, despite the fact they've got amyloid in the heart. The other problem in ATTR amyloidosis has been that echocardiography is not terribly sensitive. So the usual test for the investigation of breathlessness from heart disease, in other words, heart failure, the first test that is done usually is an echocardiogram. And the problem with echocardiography is it's very difficult to differentiate cardiac amyloidosis from what we call hypertensive heart disease related to high blood pressure, or hypertrophic cardiomyopathy, other causes of thickened heart walls. And so very frequently, patients would get told, you have hypertensive heart disease, you've got a bit of heart disease related to your blood pressure, and off you go and get treatment by your GP type thing. And so the diagnosis was missed. As Mary said, what we really need is more awareness and early diagnosis. And in order to achieve that, we need clinicians to suspect the diagnosis in the first place. This is data here from a study that we conducted some years ago, these two panels on the right, and pretty depressingly, they show that 42% of patients with cardiac ATTR amyloidosis were diagnosed after 4 years of having symptoms. And the average number of hospital attendances in patients before they were diagnosed with ATTR amyloidosis in their hearts was 17, as you can see there. So that shows you that clinicians, even when patients attend hospital and see cardiologists, some years ago anyway, clinicians were not thinking of amyloidosis as a likely diagnosis. So really we need cardiologists and neurologists to be thinking outside the box perhaps, or at least to be aware of cardiac amyloidosis as a possible cause of any patient with heart failure in association with a thickened heart wall. So we need to raise awareness. And from a cardiology perspective, if you've got a thick heart wall, think amyloid. And as Mary said, from a neurological perspective, I think things have improved dramatically. The reason that the numbers of diagnoses, as you saw earlier, have gone up dramatically in recent times is really down to two tests. One is cardiac MRI scanning or magnetic resonance imaging, which has been used more and more widely for the investigation of heart failure. And this is a study that was conducted some years ago, which showed the typical feature of late gadolinium, what we call late gadolinium enhancement. When you have an MRI scan, people inject some dye, if you like, and essentially you get a very characteristic picture as that dye diffuses through this expanded space, which is occupied by amyloid deposits. And so the diffusion of that dye just takes longer because that space is expanded. And so you get this very characteristic picture, which everyone will pick up as cardiac amyloidosis. The other test that's been incredibly helpful and useful and is exquisitely sensitive, we now know, is DPD scintigraphy. DPD is a bone tracer, and DPD scintigraphy is a type of scan that was used as a bone scan in this country some years ago. There are actually a number of different bone tracers, and DPD is no longer used as a routine bone tracer in this country, but it is, for example, still used in Italy as the main bone tracer. But DPD scintigraphy, we discovered, and actually a chap called Claudio Rapezzi, who worked in Bologna in Italy, was started looking at DPD scintigraphy very systematically. And what he identified was that it's exquisitely sensitive. If you have ATTR amyloid in your heart, DPD scintigraphy is more than 99% certain to pick it up. And he came up with this grading system related to the intensity of uptake in the heart, as you can see here on these pictures, in relation to uptake in the bones. Here you've got, this is a normal bone scan in a patient without cardiac ATTR amyloidosis, and you've got, you can see all the bones beautifully demarcated. Here you've got a little bit of uptake in the heart, which is less than bone. And here you've got uptake in the heart, which is more than bone, grade 2, with a bit of attenuation, a bit of reduction of the bony signal. You can't see the bones, the long bones in the legs here quite so clearly. And here you've got a lot of uptake in the heart and almost no, in fact, pretty much no bony signal at all. So you're comparing the uptake in the heart relative to the bones, and he was able to come up with this grading system. And as a result of these two tests, some years ago, in a global collaboration with a whole range of amyloid centers around the world, we were able to establish a means of diagnosing cardiac ATTR amyloidosis without the requirement for a biopsy. As I told you earlier, the challenges of a biopsy were very considerable. And so we were able to come up with this diagnostic algorithm that if you had an echocardiogram or a cardiac MRI scan raising a suspicion of cardiac amyloidosis because of thickened walls or this late gadolinium enhancement that I told you, if you then do a bone scan, which shows either grade 2 or 3 uptake in the heart that is greater than uptake in the bones, and then you do a blood and urine test specifically looking for a paraprotein, or specifically looking for what we call a monoclonal protein. And the reason for that is to exclude AL amyloidosis, which can give rise to this grade 2 uptake. If you don't have evidence of a monoclonal protein, then on that basis, you can make a diagnosis of cardiac ATTR amyloidosis. So just to recap, an echocardiogram with thick heart walls, a bone scan showing grade 2 or 3 uptake, and then some blood and urine tests showing no evidence of a monoclonal protein in the blood or urine, you can make a diagnosis of cardiac ATTR amyloidosis in a patient with heart failure, I should say. And all that's left then is to do a genetic test to work out, is it hereditary ATTR amyloidosis or is it wild type non-hereditary ATTR amyloidosis? This is what we have been doing at the Amyloidosis Center, just to highlight the fact that we have been running a sort of one-stop shop so that patients with a suspicion of amyloidosis come to our unit, or a diagnosis based on a biopsy come to our unit. Many of you will have experienced a 2 or sometimes 3-day stay in a hotel across the road, during which you undergo a whole range of tests. It's a pretty intensive couple of days, and you can see that 1999, when Philip Hawkins established the Amyloidosis Center as the National Amyloidosis Center, we did very few tests. 20 years on, if you like, we do a huge range of tests you can see over the course of those 2 days. And at the end of the 2 days, hopefully we make a firm diagnosis. Have you got amyloid? What type of amyloid is it? Which organs is it affecting? And how severe it is, and can recommend some treatment. Once you do make the diagnosis of ATTR amyloidosis, by the time the diagnosis is made, you can see these are, this is quality of life, measuring quality of life and a whole range of factors associated with quality of life. And the normal quality of life, the circle should be up here somewhere above 70. And what you can see is that quality of life in patients who, at the time of diagnosis with ATTR cardiomyopathy, which as I said is often very delayed, is significantly reduced. And many of you will be more than aware of that. And this is just data just showing that at follow-up, as Mary alluded to, this without treatment, ATTR amyloidosis and cardiac ATTR amyloidosis is a progressive condition which gets progressively worse. Once we do make the diagnosis, we can now stage the disease very easily using two simple blood tests, essentially. And on the basis of those blood tests, we can stage cardiac ATTR amyloidosis into stage 1, 2, and 3. And that allows us to give an estimate on prognosis and an estimate on the likely progression of this condition. In terms of the management of cardiac ATTR amyloidosis, in terms of symptomatic management, first of all, the main management thing that we try and control is fluid retention. Patients with cardiac ATTR amyloidosis, like any other cause of heart failure, tend to retain fluid. And so what we need to do is help the body to get rid of fluid by asking patients to put less in. So many of you will be aware that you've been asked to restrict your oral fluid intake, typically to about 1.5 liters over 24 hours. And that's including soup, including tea, coffee, any water, the total fluid intake to about 1.5 liters. And then we give diuretic tablets, water tablets, to try and increase your getting rid of fluid, increase urine output to get rid of fluid. And typical diuretic tablets would be furosemide, bumetanide, and another tablet called spironolactone. Many of you will be aware of those tablets. Patients with cardiac ATTR amyloidosis often have low blood pressure. And some of the tablets that are used routinely to treat heart failure can exacerbate that. They can make low blood pressure worse. So actually, quite often at the Amyloidosis Center, we are actually reducing some of the tablets that are given as a matter of course by many cardiologists for heart failure, but haven't been directly shown to benefit patients with cardiac ATTR amyloidosis and sometimes worsen symptoms through the lowering of blood pressure. We try and control heart rhythm. Heart rhythm, when you've got cardiac ATTR amyloidosis, the heart sometimes beats more quickly. And there's a particular irregular heart rhythm called atrial fibrillation, which is quite common in the context of ATTR amyloidosis. And similarly, sometimes the heart can beat more slowly, what we call bradycardia. And again, some of the treatments that we use to treat heart failure in general, for example, beta blockers, can actually slow the heart down. And sometimes we end up withdrawing those drugs because patients' hearts are beating too slowly. And many of you will be aware that patients with cardiac ATTR amyloidosis whose hearts slow down too much sometimes need pacemakers. So control of heart rhythm is an aspect. And then, as Mary alluded to, maintenance of muscle mass. Patients with heart failure in general and cardiac amyloidosis as a cause of their heart failure, invariably, even if they haven't got autonomic neuropathy, which will make weight loss worse, even just wild-type ATTR amyloidosis simply affecting the heart will typically cause loss of muscle mass, probably partly because of the direct effect of amyloid on the heart, but also partly because patients can't exercise as much because of the breathlessness, because they're fatigued. And so we want to try and maintain nutritional status. We want to try and maintain muscle mass. And so a high protein intake, if at all possible, and also exercise, which, as Mary alluded to again, needs to be tailored to the particular patient. But we've got no strong evidence that for a patient with cardiac ATTR amyloidosis, pushing themselves a little bit and allowing themselves to get a little bit breathless is necessarily a bad thing to do. Obviously, not overdoing it's important, but at the same time, taking some exercise is recommended. So let's turn our attentions to treatment, and particularly in terms of the treatment principles. So the main principle of treatment in every type of amyloid, and the reason we need to know what type of amyloid we're dealing with, is to lower the concentration of the protein that makes the amyloid. So in this case, lower the concentration of TTR in the bloodstream. Transthyretin, the protein that is making the amyloid we're talking about, is a normal protein that circulates in the bloodstream. And What we want to do to treat this form of amyloid is to reduce the concentration of that protein in the bloodstream so that there's nothing available in the bloodstream to misfold and form more amyloid, if you like. And that is how patisiran, these new RNA inhibitors, patisiran and inotersen work. They lower TTR levels in the bloodstream. I'll just show you some data. I apologize for this slide. It's pretty busy, but it's just, I think you should concentrate on these scans here, which are SAP scans. I haven't talked about these particular type of scans, but they're scans that look at amyloid in other parts of the body. And these are patients with a different type of amyloid, just to show that if you reduce the concentration of the relevant protein, what you can get is regression of amyloid, removal of amyloid. So you can see over the course of 2 years here, these are anterior whole body scans. This is a liver and a spleen in a patient. And you can see 2 years later, there's less black in the liver. The amyloid in the liver has regressed, and the amyloid in the spleen has also regressed. But you can see it's taken 2 years, and you can still see some amyloid in those organs. So you can see the amyloid regression, even after you reduce the concentration of the relevant protein, happens very slowly. And this is the same in a different type of amyloidosis where you've successfully reduced the concentration of the relevant protein. And you can see regression of amyloid again from the liver and the spleen. And this really highlights the different rate of regression of amyloid from different organs. You can see the liver was hot, very black there, and it's much less black there. The spleen is still pretty black. It's shrunk, so there has been regression, but nonetheless, there's been less regression probably than in the liver there. And these are MRI scans, serial MRI scans, performed by Mariana Fontana, who runs the MRI unit here and has been instrumental in developing MRI scan for cardiac amyloidosis, showing that amyloid can also regress from the heart. This is AL amyloidosis, so this is a different type of amyloid, but if you suppress the underlying condition, suppress the relevant protein, amyloid deposits can also regress from the heart. The patisiran phase 3 clinical trial, which led to the use of patisiran in the NHS, was primarily a neurological study for patients with hereditary ATTR amyloidosis, and it was primarily looking at neurological endpoints, the effects of these drugs on the nerves, as Mary mentioned earlier. But I just wanted to touch on the fact that they also probably benefit the heart. And this is data from the same trial. So these were patients with hereditary ATTR amyloidosis, and these were the cardiac subpopulation. So a proportion of the patients in the trial had both amyloid in the nerves and the heart. As we talked about earlier, hereditary ATTR amyloidosis commonly affects both. And although the trial was focused very much on the heart, nonetheless, amongst the patients with cardiac involvement with amyloid cardiomyopathy, there was evidence, albeit quite subtle, of benefit in relation to a number of parameters which we use to measure heart function. Echocardiographic parameters here, a blood test showing a slight reduction in patients on treatment compared to an increase in placebo. Reduction is in the right direction, suggests the heart's improving. And here you can see that a marked worsening in patients not on treatment, and much less worsening, if any significant worsening at all, in patients on treatment with patisiran. So, and functional worsening of functional status in patients on placebo, and stable functional status, or possibly very, very slight improvement of functional status in patients receiving treatment. So there was evidence from the study that these drugs also, or that patisiran benefits the heart. And similarly, this was an analysis that was done after the completion of the study. So it wasn't taken as part of the study, but after completion, this was an analysis from the data obtained from the study showing a reduction in the number of hospitalizations, all-cause hospitalizations, so hospitalizations from any cause, but also a marked reduction in patients who are hospitalized for cardiac causes in patients on the drug compared to patients on placebo. So evidence that the drug benefits the heart as well as the nerves. The other modality or the other treatment strategy for ATTR amyloidosis is to try and stabilize the TTR protein. So one is to get rid of the TTR protein, as I mentioned earlier, from the bloodstream. And the other one is to try and stabilize TTR. TTR is secreted as what we call a tetramer in 4 pieces that are held together, if you like. And in order to form amyloid, it has to either be cut into 4 different monomers, monomers, or it has to fall apart into monomers and then misfold into amyloid. And what these drugs, these stabilizing drugs do, which you can see here, Tafamidis being one of them, and this new drug, AG10, they stabilize TTR to try and stop it from falling apart and thereby stop it from forming amyloid. And this was, Tafamidis is a stabilizing drug. It's a small molecule drug that stabilizes TTR in the test tube. I should say it doesn't stabilize TTR completely. So it's not, it's not a good enough drug to completely stabilize TTR, but it definitely in the test tube has an effect in terms of stabilizing TTR. And the drug company Pfizer, who make Tafamidis, developed this cardiac study essentially for patients with cardiac ATTR amyloidosis, both wild type and hereditary ATTR amyloidosis, where they randomized them to 2 doses of Tafamidis and some patients to placebo and followed them, as you can see here, for 30 months. And these are the headline results of that clinical trial. They pooled the Tafamidis group. So they reported the 2 doses of Tafamidis together. They didn't separate the 2 doses. But what this trial shows, to summarize really, is a slowing of disease progression. So what you can see here, these curves show that patients on the placebo, in terms of their 6-minute walk test, their 6-minute walk test declined at this rate on average in patients on placebo, whereas in patients on Tafamidis, it did actually continue to decline, I'm afraid, but it declined much more slowly, or significantly more slowly, I should say, than in patients on the placebo. And similarly, quality of life did decline, but it declined more slowly than in patients on placebo. And this is patient survival, and you can see here that the survival was better in patients on the drug than in patients on placebo. This new drug, AG10, is a similar drug in that it stabilizes TTR. It's made by a company called Eidos, and they are currently performing a clinical trial, which is very similar in terms of its design to the study that I just showed you, the Tafamidis trial called the ATTRACT trial, in which they randomize patients to either AG10 or placebo in a ratio of 2 to 1. So 2/3 of patients get the drug, 1/3 of patients get placebo, and they follow them up for 30 months with the same sort of endpoints as the past study. And this is a study that's currently going on in the UK that we're recruiting to. I should say that in the test tube, AG10 does seem to be a better stabilizer of TTR than Tafamidis. Whether that translates into better clinical benefit is the purpose of the trial. So we're waiting for the results of that trial. This is the state of play with new drugs in the UK. So patisiran and inotersen, as many of you will know and some of you will be on, is licensed and funded by the NHS, funded by NICE since last year for hereditary ATTR amyloidosis with neuropathy. So you have to have a genetic mutation. Patients with wild type ATTR amyloidosis unfortunately cannot get these drugs at the moment. And patients with hereditary ATTR amyloidosis who just have a cardiomyopathy with no evidence of neuropathy at all are also ineligible to receive these drugs at the moment. But if you have a neuropathy along with a cardiomyopathy, you are potentially eligible in the NHS to receive either patisiran or inotersen as TTR lowering drugs. Tafamidis is recently received what we call marketing authorization, so it's licensed for the treatment of cardiac ATTR amyloidosis by the FDA in America and the European Medicines Agency in Europe. And it's currently, there's been an early access to medicine scheme involving patients, about 130 patients in total in the UK. And the approval process for funding is currently ongoing by NICE. And we hope to hear about whether that drug gets approved fairly shortly, hopefully by the end of the year. And as I mentioned, the AG10 study, which is a new stabilizer, there is currently a phase 3 clinical trial into which we're recruiting as we speak. There's obviously been a pause in recruitment in association with the COVID-19 pandemic, but that is recruiting as we speak. There are a number of planned trials which should open either in the later part of this year or early next year. There's a study called Apollo B, which is a phase 3 clinical trial of patisiran for cardiomyopathy. So it's using patisiran specifically for ATTR cardiomyopathy. You heard that the Apollo study, the study I showed you earlier, was really focused on the neuropathy, although some patients had cardiomyopathy. This is a trial that is entirely focused on the cardiomyopathy. Helios B is a phase 3 trial of vutrisiran. Vutrisiran is Alnylam's new drug, which also lowers TTR levels, just like patisiran does, but it has the advantage of being given once every 3 months by a subcutaneous injection. So it's much simpler to give that drug than it is to give patisiran. And that drug will be tested in patients with cardiomyopathy in the Helios B study. The Ionis CS2 study is another study of Ionis Axia's next generation drug, rather like vutrisiran in comparison to patisiran. Ionis Axia have a next generation inotersen drug, which is also more convenient. It's given by a subcutaneous injection once a month. And they are going to be doing a trial in patients with ATTR cardiomyopathy, both wild type and hereditary. And that's also true for the other 2 studies above it, which I've just mentioned. It will be both in wild type and hereditary. And then there's going to be a new study, hopefully later on this year in the UK, as well as a global study from a company called Intellia, who are using a completely new technology called CRISPR, which pretty much knocks out TTR completely with 1 injection. So that's a pretty exciting potential treatment for the future, in which one may be able to knock out TTR pretty much completely. What we don't know yet is whether knocking out TTR completely will be a safe thing to do. But if it's a safe thing to do, it's likely to be a very beneficial thing to do in patients with cardiac ATTR amyloidosis. This is a patient who has hereditary ATTR amyloidosis and has a combination of neuropathy, nerve involvement, and cardiomyopathy. And you can see this is his anterior whole body DPD scan showing cardiac uptake. This patient started patisiran as well as a TTR stabilizing drug, diflunisal, which I haven't talked about here today, but that's another TTR stabilizing drug. He started the combination of those 2 drugs some years ago, and this is a scan taken 2 years later, and you don't need to be a nuclear cardiologist to see that there's a reduction in uptake in the heart. So that's encouraging. We still don't quite know what that means, and I think there's a lot more work to do to see if we're really seeing amyloid regression and whether the scan changes really represent direct improvement in the heart. But it's certainly encouraging. It's not something that we'd ever seen before these disease-modifying treatments were available. So just to summarize, it's obviously exciting times. There's a lot going on in ATTR amyloidosis. To echo what Mary said, what Carlos said, what all of us have said, I think what we need is earlier diagnosis. And there's evidence that that's happening already with the non-invasive diagnosis possible in about 70% of patients. But really what we need is awareness, awareness, awareness. And I think, you know, what the association is doing, Carlos and company are doing to raise awareness is exquisitely important. Every single treatment for any type of amyloidosis has been shown to be more effective the earlier a patient is treated. So we really do need earlier diagnosis. And then there are a whole range of drugs that are either already or becoming available. We've got clinical trials with newer agents and exciting, very new agents like this CRISPR technology. And we've got work to do to know whether the combination treatment with a stabilizing drug and a drug to suppress TTR concentration in the blood is a valid thing to do. I showed you one patient who'd shown quite significant improvement, but what we don't know is whether for all patients that will be better than either just a stabilizer or just a lowering drug alone. We don't know the answer to those questions. So there's a lot of work to do. There's much work to be done by us all, but I think we need to focus on making an earlier diagnosis and getting patients onto these various treatments, getting these drugs approved in the UK, and running these clinical trials to try and use better drugs. And finally, I'd just like to thank all of the people. Well, first of all, thank the association, thank all our collaborators and colleagues and people who refer patients to us, and then thank my many, many colleagues at the Amyloidosis Center, and in particular, Philip Hawkins, who is the unsung hero and really is responsible for setting up the center and developing much of the work that I've shown you today. So thank you very much indeed.